Well, hi, everybody. Thanks for joining us today for our discussion on operationalizing electronic health information, or EHI definitions, which I know is a huge mouthful. I am Jen McCann. I'm the Director of Client Relations and Strategy at Haugen Consulting. I'm excited to introduce my co-presenter today, Mary Beth Haugen, who is our President and CEO at Haugen Consulting.
All right. I'd like to start off before we jump into the presentation is just kind of put this disclaimer in there because we've had so many internal conversations and information is changing that really know that what we're trying to do today is just provide some guidance, some education. As you dig into this, please make sure we want to encourage you to research any subsequent official guidelines. They're changing rapidly. Just kind of know we're here to provide, scratch the surface, give you some good information. So let's go ahead and jump into the agenda and what we're going to talk about. So the first thing is really understanding our designated record set. And Jen is going to walk you through those definitions and kind of where we came from and where we're going. And then we want to talk about the ins and outs of what are we going to include? What do we have to include? What do we have to exclude? But there's a whole little gray area or a whole big gray area in having this conversation. And so Jen and I are going to walk through some real life scenarios or things that we've encountered to hopefully help you create questions and thoughts that you can take back to your organization. And then we really want you to recognize that the DRS is kind of that. We're looking at it as that intersection or that foundation between information blocking and the HIPAA privacy rule, and really how it complements each other, because we're a glass half full kind of group. And so we're going to look at the positive and really just kind of, this is what we're dealing with, what we have to deal with. So let's go into it with a positive attitude.
I love that.
Yeah.
So thanks, Mary Beth. Like Mary Beth said, I'm going to give us, kind of that how did we get here and kind of that foundation that'll help, I think, with this discussion today. So sort of the how did we get here, the term designated record set, it's not new. It was initially defined as part of the HIPAA privacy rule, right? But for years in HIM, when we thought about kind of operationalizing the DRS, we really were looking at those elements of our record that we weren't going to readily release, right? When I think back to when I was sort of working on legal health record and designated record set activities, the things that fell into the designated record set were those things that could be requested, but weren't really part of our kind of day-to-day and what was generally released. And so, it's interesting because now we find ourselves here and we're coming back to this definition. And so here the definition, like I said, it's the same as it was in HIPAA. And when we look at how you operationalize this, this is it. This is the definition that we have. So let's kind of pick it apart for a second. It's those records that are maintained that include the medical records and the billing records, right? So we've got enrollment, payment, claims adjudication, case management, all those elements. And then that third piece of the definition is what's going to be really vital in a lot of the conversation around operationalizing this. It's that information that was used in whole or in part to make decisions about an individual or about a patient. And remember, it's not what was used, it's theoretically what can be used. So it's all those data elements, all those pieces that can be used to make decisions about an individual. And so really, where did the designated record set sort of get, revitalized? Where did it kind of come back into view? Well, we fast forward to a handful of years ago and the signing of the 21st Century Cures Act, which now started to point us back to that definition of the designated record set. And really, in order to kind of inform this information blocking definition. So the Cures Act is also what gave us this term information blocking. And these are those practices that would really otherwise inhibit or prohibit the expedient access to electronic health information. And that term, electronic health information, or EHI, is another term that was new to us as far as, the Cures Act. We're well familiar with protected health information, PHI, electronic protected health information, ePHI, but now we sort of get this EHI definition as well, because all that EHI is what we can potentially be accused of information blocking if we're impeding that access. And as far as that timeline, I mean, we're here, right? We are not talking about implementing this. Hopefully today's discussion gives you some food for thought for how you continue to do this work. Because really, since that, what was called in the news that data liberation day, since October 6th of 2022, EHI is really all of that information that is in your designated record set. And all of that information must be, readily available, readily used, released if it's requested. Otherwise, we're potentially committing information blocking. So let's stop here for a second too and talk about that term EHI. So what is that? So the ONC, or the Office of the National Coordinator for Health Information Technology, my gosh, with these acronyms, but they have put together some really great resources as well. If you haven't gone to that healthit.gov website, I definitely encourage you to do so. This here, I sort of look at this as like a decision tree when you are trying to determine what is EHI. Of all this information in your systems, what meets the definition of EHI? So that first decision point is really, is it individually identifiable health information that's either maintained electronically or transmitted electronically? Okay, so we know it's electronic. We know it's, individually identifiable. It's that protected information. That second step really, again, comes back to that definition of the designated record set. Does it meet that requirement? Is it medical records or billing information used in whole or in part to make decisions about the patient? So we then have to ask ourselves that question. And if we're saying, yep, okay, it meets that criteria. The third question is really around whether or not this element of information is excluded from the EHI definition. And we're familiar with some of those exclusions, right? Psychotherapy notes have always been, excluded, right? We have those excluded within HIPAA. There are other pieces of information that are excluded. Any information compiled in response or anticipation of any kind of litigation, criminal, civil, administrative actions. And then de-identified PHI. So again, when you think about that first step in this decision tree, is it individually identifiable? If it's been de-identified, then it's not, right? It's automatically excluded. And again, on this tip sheet or this fact sheet, there is a sort of full list of those elements that are excluded. But when you look at how to operationalize this and how to really wrap your arms and your processes around this, you really need to first understand if the information you're talking about meets that EHI definition. Because when we talk about creating that scope of our designated record set, this is another infographic that comes from that healthit.gov site. But this really shows, if you follow that little gold border, that really shows us what is a part of our designated record set. What is that scope? Because there will be electronic PHI, EHI elements that are outside of your designated record set. And as you make those decisions and those determinations, you define it as such and you say, yes, these are in and these are out. But also, looking at that right-hand side of that little graphic and remembering that you may have a paper portion of your designated record set. I don't want us to lose sight of when we talk about the Cures Act and information blocking, it's all around electronic information, but you may still be maintaining paper records, and that's a paper portion of your designated record set. So just don't lose sight of that as well as you start to kind of, work through these.
But Jen, what about the legal health record? I even wanted Jen to include it in the title, but she wouldn't let me. And I think because so many of us are still using this term legal health record, it's what we can relate to and understand. And so know that all of this information is helpful. All the work that you've done related to your legal health record is going to be critical in this process. But, I know we're not the only ones kind of wondering this. And there is a great article from the National Library of Medicine that we did include in the reference resources, and just encourage you to go in and read it. And it really kind of talks about the take of incorporating all of this information. But in speaking with some of our colleagues, some of them have moved away from the term legal health record and are only utilizing the designated record set. So I think it's a nice conversation to have, like, how can they do that? What does that mean? And as Jen was kind of defining it, starts to kind of make more sense as to why that term might not be used in every organization. However, culturally, your organization might be really embedded in that, might understand it. So it's not like you can't continue to use that. It's just, how are you going to define it? How are you going to train on it? How are you going to articulate it? So I like to think it's really not gone away, but we're just figuring out how to incorporate it and really utilizing it. And know for sure all of that work that you've done and maintained related to your legal health record is only going to really help and jumpstart all of this. So why don't we go ahead and jump in and talk about, some of these different stages and how do we operationalize it, because we've talked about that and that we know that's important. It's really, taking this concept and turning it into something measurable, creating and ensuring that we have processes that are consistent, that are repeatable, around talking about electronic health definitions and how do we, apply that to our designated record set. So we want to be able to put these practices put these definitions into practice. So let's remember, this is not a one and done, unfortunately, the same way with all the work that you did around the legal health record. It's going to be an ongoing process. So we want a tool and a process that is maintainable. So to get started, we're going to look at that inventory. So if you don't have an inventory of all your systems or where all of that data is, that's the place that you want to start. Is we need to understand where EHI lives today and making sure that we've documented those systems. And step two, it's like creating that process. So now that we've understood where everything is, do we understand the process around that data? Who's accessing it? Where is that data flowing? Because then you might potentially find one or two other systems that you might not have been aware of that you want to make sure and inventory it. Who can access this information? Is anybody releasing, this information from that particular system? So really understanding the process and what you're going to do with it. And then taking your inventory, your new processes, and ensuring that you're training. And who do you need to train? What do you need to train on? How are you going to make that happen? Is really your third piece. And then assess that information. Assess your whole process. You're going to also reassess. But in assessing your process, you want to make sure that all of the work that you've done is sticking, and that people are competent in what you've trained them. And when you're going back, you're not hearing, what are you talking about? Nobody told me about this, or I don't remember being trained on this. So we want to make sure that we've got competency covered and that that communication is out there and people are able to articulate exactly what you have operationalized. So let's talk about, where these systems are, because we don't want to forget, we all have our primary systems and it's like, whew, everything is in my primary system. But is it? You've got to remember we've got all of these secondary systems that we're adding in. It might be big. It might be your PAC system or your lab system, but we also have smaller systems or scheduling systems or I don't know, numerous systems that are helping support our clinicians and helping support our finance team in getting the patients what they need. So we want to make sure we're looking at all of those secondary systems and factoring them in as well. And then archive data. We've all moved different systems along the way, and maybe we put things in a data warehouse. We've archived different information. Do you know where all of that data is and where all of it's archived? And then some organizations have had to keep their legacy systems up. Maybe it was cost prohibitive to move all of that data out of the legacy system, and it was easier just to maintain it and access it and retrieve it as needed. And so understanding those legacy systems, or you might have assumed those legacy systems went away when you transferred those data elements over, but did it really? So having those conversations with your IT folks to make sure that you know what legacy systems still have some EHI and making sure that you are documenting them. So now the time for the big discussion, the ins and out. And while the Cures Act pointed us back to the designated record set, or pointed us back to HIPAA's definition of the designated record set, that's really all that we have. And it's not all specific. So really that true definition is going to be up to your organization or your practice in order, to maintain and define really what this is. So we always want to go back to when we're looking at including or excluding, go back to your DRS definition. If that information is being used to make decisions about the individual or about the patient, it's included. And then we do have our list of exclusions, but then we have this whole huge gray area. And it's like, what do we do with that? And some of that, when I'm talking about the gray area, preliminary findings, we're going to talk a little bit more about that. Pended notes, those type of things are kind of all falling into that gray area. And so the key to determining the exclusions is making sure that everyone in your organization can articulate why you've chosen to put this into the exclusion bucket. And not only having that conversation with the team that is making that decision, but really understanding too what's going to be released. And let's not forget about the patient portal and everything that's flying in and out there. So decide your ins and outs, and then always make sure that reasoning, or you can articulate it, but that's really tight. And finally, there's a qualifying exception that precludes data or information from being considered as part of our designated record set. And the Cures Act outlines those 8 exceptions. And we're going to talk about those 8 exceptions in a greater detail a little further along. But some of those exceptions might be, your organization is under a malware attack, or is being held hostage. Unfortunately, those are some of the things that we're seeing. And during that period of time, you might not be able to provide that release or share that information. So just some different things to talk about. But there's so much, and there's a lot of really great information out there and resources for you. One of our favorite is the Sequoia group. So we've included a link to their information. So I would definitely check that out as well. So like I said, this big giant gray area, it's just not easy, and it's not something that we would want you to do in a silo, and for you to determine it's like, nope, this isn't going to be included. Jen and I put together a list of people or departments from your organization that you might want to consider having at the table when you have this conversation. You're going to know who's best to be at the table, but we wanted to give you kind of something to react to or something to consider. But it is going to be critical because you got to make that determination and then you have to operationalize it and you have to train on it. So having those conversations and discussions while you're figuring it out is really critical in order to be successful with it.
Yeah, it's so much good conversation, Mary Beth, about kind of what to consider in these ins and outs and kind of, theoretically what to do. I think it still might be confusing for folks. And I think it might be helpful for us to kind of walk through some of those scenarios, especially in those gray areas, and kind of talk about the conversations that, we've all been having internally too. So I'm going to pick on that first topic that you mentioned, that draft documentation, whether you want to call it draft or what have you. But I want to get your insight on, how you would really kind of tackle this piece, this gray area.
Yeah, absolutely. And you make a good point, like draft documentation or what we call it. So I think that's kind of the first step in this is really defining, what do you lump into this category? When you're referencing preliminary reports or interim, are you talking about your lab and your radiology and your pathology? When you're talking about pre-charting, is it a note started before surgery? Maybe not finished, or those dreaded pending notes that I think we've all dealt with where, a provider has started documenting and for some reason gets called away and is unable to finish that note. What do you do with that? What does that look like? Who can access it, et cetera? Student documentation is a biggie. And also remember, we have our medical students, but you may have respiratory therapy students, you may have, nutrition students, whatever, but what are you going to do related to that student documentation? Are you going to wait until that student documentation is signed off on by the supervising provider? Are you not going to use it, but allow the supervising provider, to take a portion of that student documentation? So you want to factor in what's best for their education, but then how are you going to manage that documentation? And then it was really interesting for me, who recently, went through a procedure scenario and, being the HIM professional that I have, man, I've got my portals, I know what's going on. I want to look. And as soon as something is dinging my portal, I'm in there and I'm looking at all of these interim lab results. I'm looking at a preliminary pathology report, all kinds of things that now I think is super cool that I have access to. And it really made me think, it's like, gosh, if this were my mom looking at this, would she be able to understand, like, wow, this is an interim or this is a preliminary report and it's not necessarily final. And so I'm reading this, but when I have the discussion with my PCP, maybe they're looking at that final result at that point. And so do we have any discrepancies? So how is the organization, talking to the patients about what they're seeing within the portal? How are we kind of eliminating some of that confusion? How are we accounting for that data and information as it relates to when we do release, down the line? How it might happen. So it was a really interesting scenario because I think it's really great for us to have this information. I like it as a patient, but really factoring in how are we managing that as an organization, how have we folded that in, and how are we educating not only our internal staff on being able to have that conversation, but also our patients. One of the other scenarios that we've been up against is really being able to articulate, let's pick on preliminary radiology results. So, do you as an organization version this? So you're only releasing the latest version. You're only releasing once that document is signed off on. However, we all know it's like, oh, well, care was provided during, this version of it. So we're going to maintain that. But in kind of a normal scenario, are you able to articulate how that flow happens why you wouldn't release a preliminary document once you have a final document. And can you have that conversation with internal counsel or with your attorneys? Or can you articulate that to the judge when you're talking about why you didn't release that preliminary finding to opposing counsel? You know, you have nowhere that you're showing that care was provided on that preliminary finding. However, are they looking at it that you're not truly releasing everything, and, you know, why not? So not only is it important for you to have that conversation, but there are other members of your team that might be being deposed. And so can they articulate that as well? So we want everybody on the same page and really truly being able to articulate what your processes are. And I know Jen has run across some interesting scenarios as well. So I don't know if you want to chime in at this point and share.
Yeah, you bet. You bet. Oh, I know. These are like the stories from the front lines, right? But I think about back in the day with this preliminary reporting or pended notes. I think I'll pick on pended notes because at the, back in the day, pended notes were just that. They were, incomplete. No one could see them really except HIM and that provider, that, authoring provider. But in this scenario, I think about it and I think, gosh, if they are out there, who can see them and who knows that they're out there? And then I think about consulting engagements we've had where we start diving into work queues and there's this weird rogue work queue hanging out over here and it is 8,000 pended notes sitting out here in a work queue, and that the system didn't sort of drop them out when the document was finalized. So I think about a lot of that operational piece and just making sure that once you make these decisions, that you really know how your system treats those pended notes, how, who does see them. If you're saying they're not included, yeah, there's so many scenarios in that one, right, Matt? That is a crazy big topic.
Yeah, and it's just a great opportunity to have some things to start the conversation with. So I'm going to pick on Jen for the next one because, this is another favorite of ours, that provider to provider or provider to patient, like I mentioned, that communication that's occurring. So Jen, why don't you share a couple of your scenarios?
You bet. Yeah, this is another big one. And I do sort of think back to when I think about provider to provider communications, and kind of how to approach that conversation with your providers. In a way, it does remind me of when we had to have the conversation with providers about open notes, right? And what a big sort of culture change and thing that was when a provider realized, hey, the note that I write is going to be read by people. And so it's that same idea and it's that same communication and discussion. Do your providers know if this information is being included in the designated record set and then can be released? So as you make those decisions, there's a lot of that communication that's out there. Secure emails and secure chat messages to me are sort of the, I don't want to say easier, but they're the easier ones to sort of say, yeah, we're counting it in and it's easier to maybe fold it into my system. Not as easy when then you start talking about texting, right? And we know that happens. We think about those scenarios like a trauma case and a provider is, sending a photo to another surgeon that they want to consult with on an amputation case, right? That's certainly some communication there that's going to be used to make decisions, but how do you, if you've excluded it, how do you exclude it? Or, just getting your arms around this. I think COVID, it's an odd sentence to say, I think COVID helped us a little bit, but obviously COVID really made us have to utilize telehealth. And so I think there is so much of that going on in, other methods, like some of these scenarios where providers are, either remote or one's remote. And so some of that might have been easier to kind of fold in, but not all of it. And then those patient to provider communications too, Mary Beth. You talked about the portal, all that communication. I think a lot of us that work in the industry, we get savvy and we know that we have methods to communicate with our providers. And I know I use them, but I don't always think about, gosh, is this communication now going to be part of my record? Is this part of the designated record set or not? And so another big piece as you work through this is, like I talked about with that conversation about open notes, is the appropriateness of the communication and the appropriateness of the documentation. And I am going to, and Mary Beth always reminds me, she's like, Jen, you can't just think about providers, right? It's not just our docs, our physicians, our mid-levels, it's all of these other clinicians that document. Think about that whole care team, the respiratory therapists, the dietitians, the case managers, and making sure that when you are making these determinations, and if any of this is going to be a part of your designated record set, that you train all the documenters, that you're not just having this conversation with kind of, your docs, that everybody needs to know that there's a level of appropriateness that has to happen, and that, yes, this is going to be a part of the record. So yeah, this is another big one.
Mm-hmm. Well, I think we even have a bigger one. Maybe we kind of started small and continue to go big, but the sensitive information, I think, is really key for us to talk about it. And I know, Jen, you're particularly passionate about this. So why don't you kick it off, and then we'll have the conversation.
Thanks, Mary Beth, if you don't mind. I do. I always, when I start to hear about behavioral health documentation and folks start to use that terminology, sensitive information, I start to think about how we can sometimes misinterpret things like what is a psychotherapy note, and we can really start to build barriers in that exchange of behavioral health information that is not psychotherapy notes, right? That really needs to be shared for that continuity of care. So I like to just put that out there. When you are making these determinations around sensitive information, if you do have psychotherapy notes in your system, that's one thing, because we know they are an exception. But really think of it as kind of staying in your lane with that and really limiting that to true psychotherapy notes, because I've seen it be sort of, again, overinterpreted. And now we have information about the treatment and the modality of treatment for patients, the medications prescribed, the diagnosis of the patient, and we have that hesitancy to release that to the patient's primary care provider. And that is where, it's just really important to not treat all behavioral health as kind of a hands-off, and really understanding how to make those decisions.
Absolutely. Well, it's changed over the years, and I think, providers are really seeing initially, way back prior to the Privacy Act, we almost isolated it a little too much. And so in order to really treat the whole patient, we need to really truly have that balance, for sure. So
yeah, but I'll say, Mary Beth, there's not all of these elements here in the sensitive information are behavioral health related. And I do want to have you share, a couple of examples from your perspective too.
Yeah. And I think the biggest one when we share this and we get questions, it's like demographics. How, why is this falling into this area of some sensitive information? And I can tell you personally, as a former foster parent, that demographics to me was truly sensitive information. It was critical, from a safety perspective, that our demographics, where we lived, et cetera, were not being shared during that certain period of time. And so really kind of understanding where there's particular scenarios why demographics might be important, really communicating and educating some of your different staff around that, because I think initially a lot of us are like, no, it's behavioral health or it's research. That to me is pretty common sense, and, we've kind of all heard that over and over again. But the demographic piece can also be incredibly sensitive as well. So having those type of conversations, I think, is important. And for me, that was a really key one, not only the behavioral health side, but also this demographic component of it.
Absolutely. Yeah. And I just always go back to this again. If you're, as you're operationalizing this and you're really digging into that sensitive data, just ensuring that your system, your EHR, can really segment this data. If you determine these elements, these data classes are not a part of the DRS, or, we're going to make sure, like your scenario, Mary Beth, this is a, foster parent. You've got to make sure that your system will really help you put up that additional protection.
Yeah, absolutely.
Awesome. And this does kind of dovetail into the conversation about those exceptions. So I do want to take a couple minutes here and kind of talk about those exceptions to information blocking. The Cures Act really gave us these scenarios or these practices that would not be considered information blocking. And in my mind, I kind of think about, sort of the HIPAA's giving us treatment, payment, and healthcare operations exceptions, right? Like it's a way to kind of balance that there's going to be, challenges in doing something. And so we want to make sure that in certain circumstances, you wouldn't be accused of information blocking if they meet these exceptions. And there's two sort of buckets of the exceptions. There's exceptions that involve not fulfilling requests to use, exchange, access information. And then there's exceptions that involve procedures for fulfilling requests. And the biggest thing I hope folks take away from these is that exceptions are really just that. They're exceptions to the rule. So they're not the norm. And, it's that cautionary tale of, don't lean on these. You are definitely going to be, you as the organization, you as that covered entity or that actor, as the term comes out of the Cures Act, you are going to be the one that holds the burden of proof to really show that this was a valid use of an exception. So don't sort of lean on these as like, well, I didn't release this, and I'm sure I can kind of dovetail or fit this into one of these exceptions. They really are exceptions to the rule. I also will say that of all the information that is out there and available on these exceptions, sometimes it's not really great to understand what they mean in a real life scenario. Mary Beth talked about one earlier, and some of these on this first slide, I've kind of broken them up in two slides. Some of these on this first slide are a little easier for us to understand because they're not new concepts, right? Preventing harm. You can use this exception to say, this provider felt there was reasonable belief that releasing this information could cause harm to the patient or another individual. We made the decision not to release this information using this exception. That to me is a little more comfortable and straightforward. We've, had that with HIPAA, so it's not new. But some of the other ones are a little harder to kind of understand what they look like. That one Mary Beth talked about too is that health IT performance, right? You are, your organization is currently, the victim of malware or ransomware, and you just can't get into that system. So there are those exceptions that kind of protect the organization in those circumstances. But I also want to remind folks that when you use an exception, there are rules around it. There needs to be that communication with that requester within certain time frames that say, this is why we haven't released this, it's this exception. So really understanding as you operationalize those exceptions, how to use them appropriately, and how to not overuse them or sort of rely on them. That was a lot, Mary Beth. I'm going to kick it back to you on sort of that third wheel, that third cog in that cycle.
Yeah. So what we want to mention around the training is, I think one of the things is remembering, we're dealing with all adult learners. So as we're creating that training and education, ensuring that we're keeping that audience in place, in line with what we want to train. So knowing who you need to train, what they need to be trained on, and then really figuring out that delivery method. So again, it's not just kind of a check the box, but are we really ensuring that transfer of knowledge? Have we ensured that competency? So like we said, many people are going to need to be able to articulate this and be able to understand it. So have we covered all of our bases around, and especially talking with our patient access staff or our release of information folks, do they truly understand that? So making sure that you're putting together education that's going to work, it's a lot, but really going back and ensuring that competency is going to be key. And I'm going to have Jen talk about kind of one of her passions this past year as it relates to training.
Yeah, hearing you say all of that, Mary Beth, and kind of having those conversations with clients about how do I create training that's meaningful, that's scenario based, that I can measure competency on, that's not just a simple, 10 question multiple choice quiz. We heard that from our clients so often that we started having discussions about what do we do and what can we provide? And so it really grew into this 2-part online course series in Haugen Academy on release of information to really give folks a training mechanism that is standardized, that is geared toward the adult learner, right? That has scenario-based learning and not just kind of multiple choice, true or false. And it was a labor of love between, our group, the education team, our consulting team, to really put these out. And also, if you're looking at that bullet and you're thinking, holy smokes, is she going to talk about this? AHIMA is also launching a release of information micro-credential this year as well. So when you think about all of that discussion in the industry of we need to make sure that we have the right training, that it's standardized, and that we can show competency in those areas, AHIMA heard the same thing, right? And recognized there's the need for that, and there's the need to really show that our release of information staff are appropriately trained and that they have the competencies that they need to perform this work, because release of information has only gotten more and more complex. So exciting to kind of say that that's coming as well. But if you are, looking for that kind of education, I definitely encourage you to take a look at Haugen Academy and take a peek at those courses and keep your eyes peeled for that micro credential.
Yeah, I agree, Jen. It's really exciting, I think, for me, that recognition around how complex release of information has come, and to really put that micro credential in place to really acknowledge all of this training and education that these people have to have in order to do their job successfully. So I think it's really exciting. I'm really looking forward to seeing that credential released soon.
I know. Soon. Yeah. And I do want to bring it back to just something we talked about, Mary Beth talked about as one of our agenda items, really, is that hopefully now at this point in this discussion, you are recognizing that the designated record set and how you make those decisions and what you include and exclude really does kind of meet in the middle of information blocking and the HIPAA privacy rule, that they're not counter to each other. Because I do admit it was hard for me. I'm such a HIPAA privacy and security brain. When the CARES Act came out and when information blocking came out, it felt very much like a tug of war between this expedient access to more information than we've ever had before, meanwhile balancing those patient privacy rules. And we're really talking about it at a federal level too. And I know a lot of you have very specific state laws too, but hopefully you're seeing that. You're seeing that these efforts, this work can really help kind of create that balance of ensuring expedient access, meanwhile protecting those pieces of the record that need that protection.
Absolutely. Thank you, Jen. So we want to kind of wrap it up with just kind of a recap of our key takeaways and what we've kind of talked about around, starting with that inventory and how critical it is to really know where EHI lives in your organization and that you're able to identify and articulate that, and shifting that into then what's being done with that PHI and who has access to it and what's kind of happening and where is all of that flowing, and really putting into place, where we want information released from and where people should be accessing this information. And once we get those processes all in place, creating that training and ensuring, again, that we've got that competency in place and that we're giving them different scenarios so that we have that transfer of learning is really important. And then assessing, making sure, again, everything we did has really hit the mark, that people are able to articulate it, that they're able to understand it, and that we're reassessing on a regular basis to ensure that we're capturing any new systems that are coming into place or any guidelines that have been changed. So just remember, just 4 things, those 4 takeaways will really help. So we also included our page of references that we find extremely helpful. So hopefully you will too, some really great information. There's a lot of great resources out there for you. And then you can always reach out to us. So multiple varieties in order to track us down. But we hope, again, we know we just scratched the surface, but hopefully you found some of this information really helpful and that you've got some good questions to take back to your organization. So thank you for joining us today.
Thanks so much, Mary Beth. Thanks for having me as part of this conversation, and thanks everybody for being here. Bye-bye.